Hi, my name is DeAnn Rife, and today I will be presenting my DNP project titled Education Intervention to Improve Provider Compliance with Heart Failure Order Sets for Nurse 707 with Maryville University. A little introduction to the project. Heart failure is a complex disease process and is often very difficult to treat for even experienced cardiologists. Depending on the stage and classification of heart failure, there are multiple different evidence based therapies that can be given for that patient. That being said, disease specific heart failure order sets can help improve adherence to guideline directed therapies as long as the order sets were designed with those evidence based treatments in mind. Now, improved adherence to both the order set, meaning the guideline directed therapies, means that patients are going to have better outcomes. In fact, in a study by Bjerling, Schoberg et al. From 2018, patients who had heart failure order sets implemented had both decreased length of stay, decreased morbidity, and decreased mortality overall at the end of the study when those order sets were implemented. The problem that I identified when I developed this project was that there was poor provider compliance with heart failure order sets at approximately 500 plus bed facility in northern Nevada. Around 47% compliance was determined in inpatient order set usage in 2019. Now, that being said, this is before the COVID-19 pandemic hit and before there was a significant amount of provider turnover at that facility. After this 2019 compliance amount was determined, there was about 40 new providers hired on at the facility after that period of time. So provider compliance was actually likely less than that when this study was developed and also when the abstraction process occurred pre-intervention. The question that I wanted to find an answer to was, does provider education improve compliance with heart failure order set implementation over the course of 3 months post-education? The methods for this project, the study design was a mixed quantitative and qualitative experimental design wherein I did retrospective chart audits, so meaning chart audits of patients from the past, not current inpatients, but retrospective chart audits of patients who are admitted to inpatient units with a heart failure diagnosis. I did 70 charts pre-intervention. Then the heart failure committee provided education to the providers, and then there were 75 charts post-intervention that I audited. So a total of 150 charts were audited for this study. The inclusion criteria, the patient had to be admitted to an inpatient status. They had to have a discharge diagnosis of heart failure, whether a heart failure diagnosis or a heart failure combination code. They had to be between the ages of 18 to 89 years old and be either in the pre-intervention window from June 1st, 2021 to September 20th of 2021, or the post-intervention period from September 22nd, 2021 to January 31st, 2022. Now that means that the education intervention was given at a hospitalist meeting on September 21st of 2021. And for reference, all information provided at the hospitalist meetings are expected, all that information is expected to be implemented from the meeting onward. And the patient had to have an NT pro BNP value of greater than 300 during that admission. Exclusion criteria, if they were outside the age range were not admitted during either the pre-intervention or the post-intervention time period. They had no NT-proBNP value obtained during that admission, or their value was less than 300, or heart failure was ruled out during that admission. Sometimes what'll happen, the list of diagnosis of patients that I used for the retrospective chart reviews, the diagnosis may go in as heart failure when the list was made, but then after that list is made, when coding goes in to evaluate the patient, they may recode it after that list was already made. So heart failure could have been ruled out, but it may have showed up on the list. So that's why this was part of the exclusion criteria. Also, other admission reasons with a heart failure discharge diagnosis, such as a patient who has heart failure and end-stage renal disease who was dialysis non-compliant. That is a very common reason to have a heart failure combination code of heart failure with end-stage renal disease, but they came in truly for dialysis non-compliance, which is not what I was studying for this particular study. My data collection tool, I collected very minimal amounts of data, which made this study very easy to do data abstraction for. For the code, this was a code I kept the patient lists with the patient data in a separate area to maintain patient privacy. So I gave each patient a code so that if I needed to go back during the abstraction process and reopen that chart for any reason, I knew what patient that was, but the code was kept separate so that no patient privacy was violated. The admitting diagnosis was maintained and the primary discharge diagnosis was obtained, and then the NT-proBNP ranges were given, and then ED heart failure order set, so emergency department heart failure order set, yes or no, and inpatient heart failure order set used, yes or no. Qualitative data was also unintentionally collected. It was a convenient sampling. As I was going through the evolution of this project from start to finish, I became a hospitalist provider during that time, and while I was talking to some of the other providers, they started to give me information about why they did or did not use that heart failure order set. Now, the providers that I talked to were both emergency department and inpatient providers, and they ranged anywhere from 2 to 20 years of experience, and about 6 providers gave me their thoughts or opinions on the heart failure order set. The statistical analysis was done using an upper-tailed z-test for the difference of 2 proportions. The pre-intervention sample size was 75, as I already mentioned, and the post-intervention was 75. And the level of significance that I chose at the initiation of this project was a p-value of 0.05. The results of the study. Now, I've talked about discharge diagnosis codes a couple of times throughout this presentation, so I wanted to touch on this really quickly. The diagnosis codes were based off of ICD-10 coding. The most common diagnosis code for both pre-intervention and post-intervention was I11.0, which is hypertensive heart disease with heart failure. I included the pre-intervention and post-intervention diagnosis codes to see if there were any differences between the 2 types of diagnosis codes to see if that had any kind of impact. But what you can see from the table is that the top 3 diagnosis codes used were the same in the pre-intervention and post-intervention periods. There are multiple combination codes for heart failure with kidney failure, as you can see off to the left there, but there were minimal differences in the diagnosis codes from the pre-intervention to post-intervention period. The quantitative results that we found, there were 31 charts pre-intervention that had the heart failure order set implemented, and 35 charts post-intervention that had the heart failure order set implemented for inpatient units. That accounts for a 12.9% increase in heart failure order set implementation in the post-intervention education period. Unfortunately, this was not a statistically significant increase as the p-value of 0.2553 was larger than my level of significance that I set before I did the statistical analysis, which was p equals 0.05. Also, it was a low powered study with a power of 0.161507, which indicates that it was very weakly powered, meaning that the sample size was too small to truly indicate whether or not the study had a significant impact on the outcome. So even if the outcome had been statistically significant, there's not a clear indication that the intervention was the cause of that change because of how weakly powered the study was. Patient data for reference. All patient data was de-identified and we did no specific patient data was collected throughout this process, and HIPAA was maintained throughout the data collection. Because this is a compliance study, there was no patient data that needed to be collected. Here are some graphs of the results. Now, as you can see, there is a graph for ER and inpatient units. The emergency department was included at the request of the facility, even though the emergency room providers were not given the education. This was solely so that the hospital would know what level of education needed to be given to the emergency department providers. That's why you see that included, but you don't see results for that in the quantitative data that I presented. But I wanted to show you a graphical representation of the outcomes of the study, and you can see a slight improvement in the post-intervention. The qualitative results, here are just a couple of things that the provider said to me. One of them said, "Why would I use the heart failure order set? It's bulky, difficult to navigate, and it wastes my time." Similarly, another provider said, "It takes less time to put in the few orders I want than to use the order set." And finally, another provider said, "It is too much. I will only use it," meaning the heart failure order set, "if it becomes a requirement because there's too much information that I don't care about." So to discuss the results of the study, similar studies, such as a study by Kohlmauer et al. From 2022, this study used a updated order set, a new community acquired pneumonia order set with the new IDSA, or Infectious Diseases Society of American guidelines for pneumonia antibiotics. Researchers conducted education with providers about the new guidelines and updates that were made to their order set. The study demonstrated improvements in provider compliance with the order set and with appropriate antibiotic selection. Similarly, a study conducted by Pregnall et al. Found that provider compliance with recommended Sugammadex dosing was improved following an education session and implementation of intraoperative decision support tools. Both studies demonstrated statistical significance, and I believe that that may be because the studies had larger sample sizes and they were conducted over longer study periods. There were two major facilitators for my project. The Heart Failure Committee at the facility provided the education to the hospitalist team, so they were a huge facilitator of this project. They were very much wanting to encourage these providers to use the heart failure order set as it was made in this interim of the project development. This heart failure order set was implemented, and I also was part of the development of the order set as my job. That was part of my job at the time, as well as the facility cooperated with this project. Both my supervisor at the time and the hospital were very interested in this project because they wanted to see how much we could improve heart failure order set utilization with provider education. So there was a significant amount of buy-in from the facility. There were some major barriers to this project. As many of you know, the COVID-19 pandemic struck during the time that this project was implemented, which changed the face of healthcare as we know it. It led to significant provider burnout because they had increased patient loads, they had far more patients than they were used to having, and increased patient acuity. These patients were extremely sick and they had limited amount of time because they had more patients and less time to do it in when everybody was sick. So I'm sure if we were to look back over all the different disease specific order sets, there may have been decreased utilization across the board, though this project did not study that. But COVID certainly had a significant role in the barriers to this project, as well as crisis charting. Hospitalists and other providers were not required to do the same level of charting that they had been pre-pandemic, just because of, again, the increased patient loads and acuity. Some study limitations. One thing that was a major design flaw, unfortunately, that was not discovered until the study was analyzed after the data abstraction, was that education was only given to hospitalists and was not given to residents. Unfortunately, residents at our facility also admit patients and oversee their care throughout the hospital stay, and no accommodation was made to give residents this education on the heart failure order set. That means that the study outcomes are likely somewhat inaccurate, although the extent of that cannot be determined without going back and re-abstracting the data to find out whether a hospitalist or a resident admitted the patient. Thus, I recommend replicating the study with resident inclusion in the future. Another limitation that I found was the small sample size. As I stated before, the study was weakly powered. I think given a larger sample size with accommodation made for residents, the study outcomes may have been different. Insights that I found through this study: providers chose not to implement and choose not to implement it because of facility requirements. The facility does not require that this order set be implemented at this time. If the facility were to change the requirements to where the heart failure order set is required, it may change the implementation rates, but many of the providers told me until it's required, I will not use it. Also, again, the COVID-19 impacts of this study, it delayed the study several times, and also due to limited in-person meetings and limitations from that perspective, many providers may not have come to the education session because of COVID. They were allowed to present maybe on Microsoft Teams or did not come to the meeting at all because of COVID-19. So that also played into the outcome of the study. Implications of the study: of course, education should always be the forefront of healthcare. Evidence-based practices change constantly, so regardless of the study outcome, we should continue to encourage and use education. Evidence-based practices are ebbing and flowing all the time as new research comes out. That is why we must continue to educate our providers on an ongoing basis. And also, policy changes should require order set utilization for the benefit of our patients and better outcomes for heart failure patients. The hospital should consider requiring this order set be used by providers. Recommendations for future studies. Again, the study should be replicated with an improved study design that accounts for residents admitting patients, which means that these providers should be educated on the heart failure order set. Also, healthcare policy changes should require the heart failure order set because heart failure is such a complex disease process. This can lead to improved patient outcomes and decreased morbidity and mortality in the future. My conclusion is that heart failure, again, is extremely complex, but these order sets can potentially improve patient outcomes and better these patients' lives overall. And although the education intervention did not statistically increase provider compliance, education is still a valuable tool for our providers and should continue to be used regardless of this study's outcomes. And if you look at other studies, you will find that education does show statistically significant increases in provider compliance and shows improvements in patient outcomes. So, even though this study was not significant, we should still continually use provider education. Thank you so much for listening to my presentation. I look forward to any questions that you may have. Here are my references.